Hello friends, good morning. I'm Dr. Akash. Welcome to Mrcs SEO Shorts. Today we'll be discussing an very important topic, that is carcinoma of the thyroid, which definitely comes in your Mrcs part A. So let's proceed. So what's the classification for thyroid malignancy? It's divided into papillary carcinoma, follicular, anaplastic, medullary, lymphoma, and some mixed tumors. Among these, the papillary carcinoma of the thyroid is the most common. It accounts for approximately 60 to 65% of all the malignancies. The second most common is follicular carcinoma. The most aggressive form of cancer is anaplastic carcinoma. So we'll be discussing everything in detail. Let's go to papillary carcinoma of thyroid. It's the most common type of thyroid malignancy. Radiation exposure is an important risk factor for papillary carcinoma of the thyroid. So in any question, if they are mentioning about any previous radiation therapy to neck, so mostly they are indicating towards the papillary cancer. This cancer is accurately diagnosed on fine needle aspiration cytology. So what exactly we see in histology? So they may demonstrate samoma bodies. These are the areas of calcification, and we can see orphan Annie nuclei. These are non-capsulated with pale empty nuclei, as you can see from this very picture. The papillary carcinoma of the thyroid metastasize via the lymphatics. This is a very important question, and the prognosis of papillary carcinoma is excellent. Let's move on to follicular carcinoma. So in clinical presentation, the papillary carcinoma and the follicular carcinoma, they both present as a discrete thyroid nodule. Although they appear to be well encapsulated macroscopically, but there is invasion on microscopic evaluation. Therefore, the follicular lesions cannot be accurately diagnosed on fine needle aspiration cytology, and it cannot identify the capsular or the vascular invasion. That's why biopsy is preferred to diagnose follicular carcinoma. Ideally, we go for hemithyroidectomy, and then in the biopsy we confirm if it is a follicular adenoma or follicular carcinoma. And the follicular carcinoma metastasizes via the hematogenous route. So like in many of the questions, you will find a clue, that is a pulsatile bony swelling, maybe in the forehead or any part of the bone with a thyroid malignancy. So this is indicative of follicular carcinoma, and as it metastasizes through the blood, so the mortality rate of follicular is higher than that of the papillary carcinoma. There is a subtype called as Hurdle cell type that carries worst prognosis, and in follicular carcinoma the chances of recurrence is also very high. So what's the tumor marker? Like if there is recurrence, then in follow-up, if we see any symptoms of thyroid malignancy or the thyroid swelling again reoccurs, then we should go for testing of serum thyroglobulin. This is very important considering Mrcs part A questions. Let's move to medullary carcinoma. As the thyroid cancer mostly arise from the thyroid follicle cells, but there are also the parafollicular cells or the C cells. So these medullary carcinoma, they arise from the parafollicular cells or C cells, and these are of neural crest in origin. Medullary carcinoma can be familial and occur as a part of the MEN2 syndrome. It may be associated with pheochromocytoma. It spreads either through lymphatics or hematogenous as these tumors are not derived primarily from the thyroid follicular cells. As this tumor is not derived from the thyroid follicular cells, this cancer also doesn't respond to the radioiodine therapy which are directed against the thyroid follicular cells. But in histology, you can identify amyloid deposits. And for the recurrence, we can use serum calcitonin. Then let's move ahead to anaplastic carcinoma. It is less common, but it tends to occur more frequently in elderly females. As the name suggests, anaplastic, so local invasion, vascular invasion, signs of aggressiveness or anaplasia is very common in this carcinoma. The disease is usually advanced at presentation itself, so only palliative decompression or radiotherapy treatment can be offered. Unfortunately, the mortality rate is very high in anaplastic carcinoma. So how we can proceed with the treatment? Either we can go for surgery or we can go for radioactive iodine therapy. Let's see surgery. Either we can go for hemithyroidectomy or total thyroidectomy with or without neck dissection for any lymph nodes or any adjacent structures involved. So the advantage of surgery is that it gives quick symptomatic improvement, usually within 10 days, but there is risk of damage to the adjacent structures, mainly the recurrent laryngeal nerve. Therefore, the pre-op assessment of the recurrent laryngeal nerve and the vocal cord is very important before proceeding to the surgery itself. Then there is radioiodine therapy, which are directed against the thyroid follicular cells. The disadvantage is that it is slow in response, but the advantage is that there is no risk of damage to the adjacent structures. As we have discussed before, it doesn't work in medullary carcinoma because medullary carcinoma arises from the parafollicular cells or the C cells. So this is a very important topic of endocrinology for MRCS. Part A will be covering all the topics in next discussions. If you have any doubt or if you want any video in particular, please let me know in the comment section. Thank you so much.